Welcome to a Shot in the Arm podcast with me, Ben Plumley. And this is a podcast about innovation and equity in global health. Our guest today is Kirk Scirto, a doctor and global health expert. And he recently published a new book, Doing Global Health Work, a very modest title for a profoundly important set of observations from over 20 years working around the world to support local communities improve their health and well-being. His thoughts and recommendations predate to a large extent the current debates around decolonialization and localization in global health, and they offer deep, sometimes uncomfortable recommendations on what we can do on an individual level for those of us passionately committed to social justice in global health. The book, Doing Global Health Work, is published by Hesperian, a California-based nonprofit that has been providing and sharing easy-to-understand health information for people worldwide. Kirk, welcome to a Shot in the Arm podcast.
It's really a pleasure to be here. It's an honor. Thank you, Ben.
Now, where are you calling in from? Although Hesperian is based in California, you're not, right?
Yes, I'm based in Buffalo, New York.
And before we get into the global health work, I wondered if I could ask you a little bit about the clinical services you provide and do in Buffalo, New York, because you work with one of the Native American communities, don't you?
Yes, the Tonawanda Seneca Nation.
You want to tell us a bit about them, who they are, and what kind of medical needs you find that you all are having to provide?
They're very impressive people, and they're part of the Haudenosaunee Confederacy, or Iroquois, or Six Nations, as they're commonly known. So it's a very traditional nation within them, about 1,000 people. It's really been a pleasure to work with them. I consider it doing global health work within North America, driving to a different nation each day and learning so much about their culture. And it's been an honor to be a part of their medical system.
I've got to say, on this podcast, we've been very interested in understanding the health needs and creativity in delivering services that indigenous communities and nations have been able to employ. Many times, it looking like we need to learn from those communities ourselves, particularly when it comes to sort of frontline care. But I wondered, you've written this book, Doing Global Health Work for Hesperian. What got you interested in that, and why did you decide you needed to write the book now?
So many amazing, inspiring experiences in global health, and so many troubling experiences, and seeing groups, that are working very hard and have very honest intentions, but the product of their work quite often is not really empowering local communities, is not really helping them. I got my roots, essentially going on this sophomore year college trip to Jamaica. And it was joining a medical team and traveling from village to village and providing healthcare to many, many people in these settings. And it was so inspiring. We were so appreciative. And it really inspired me. I couldn't decide whether to go into clinical medicine or to go into community work and public health and global health. And this really clinched it for me. I said, I have to go into this field. I decided at that point to apply for medical school, apply for public health school.
Sort of a hand-in-glove career. Now, in the book, and I suppose this really gets us to the huge elephant in the room, you really address the responsibilities of people working in global health, particularly those from the North, in how they approach their work with different communities. And in many ways, I think you have anticipated this whole global health decolonialization agenda from a Northern perspective. And I wondered if you could just share your thoughts about that. I mean, already I can hear you talking about service and support and the privilege that it is for you to essentially provide your services to their leadership. And that's not necessarily the way that many people in the global health field feel about their work. Could you talk a little bit about that?
Oh, sure. I think it's a very accurate way to put it. I've had an easy life. I've had a privileged life. And, In resource limited countries, it is quite the opposite, and we can abuse our privilege. Again, with very honest intentions, trying to help others, we can actually disempower them and force on these solutions that we believe we have created in an accurate way, but really many times we really err. And I think I should go back to that initial Jamaica trip, because although it was so inspiring for me and I decided to go into global health, at the end of the trip, a resident was sitting around a bonfire with us and said, "Look, this trip is more about us. What are we actually doing to help the community in a long-term way?" And at the time, it went over my head. I didn't understand what he had meant. But in college, I was studying global poverty. I was studying public health, and I was involved with social justice activism, and reflecting deeper on what I learned, and going on the second trip to rural Mexico, setting up a village for one day in one community, then another village. Then I started thinking, well, what about the other 364 days in the year? What kind of healthcare are they getting? What does their local healthcare system look like? And why are we not working with Mexican providers who, of course, have a much better command of Spanish and know the culture and can follow up and know where to refer patients? They know the social determinants of health. They're the stars of care, throughout the year. And why are we doing this separate initiative? So I became very critical at this point of what I call suitcase medicine. Dropping into these communities and opening up your suitcase, dishing out medicines, dishing out medical supplies, and not doing sustainable work, not allowing the community to take center stage, and importantly, not working within their mainstream healthcare system. So I had a long journey with many mistakes that I read extensively about, and also many inspirational times when I saw communities doing amazing work and outsiders doing amazing work as well. So taking what I'd seen work very poorly in these settings, I said, I'm going to do something very different. I was following a model of essentially adopting a village in a long-term partnership led by local people. And I did this in rural Uganda, and spent a couple summers out there with teams. And so we knew that they wanted us to focus on HIV education. So we did this, and we trained peers, to be HIV educators. And we learned that the clean water needs were absolutely exponential. But by this point, I could appreciate that the public health needs nearly always, dramatically trump the clinical needs in resource-limited nations. So we're trying to focus on public health issues, and they said, we want you to focus on water. We designed a program to organize the building of wells. And this was a mistake. This was the second big lesson in global health. Local people need to lead, outsiders need to follow. I think this is critical because we made the wells. The burden was on us, and we were rarely there. Had we fostered the creation of local committees to sustain the wells that no doubt we're going to break down at some point, it would have been far more sustainable and centered on the community.
Suitcase medicine. I really love that phrase. I mean, back in the day, I remember calling it white elephant medicine, where you'd come in, do something, upset everybody, and then go away. And it has the impact, actually, of being very expensive and time-consuming for the communities themselves, not necessarily providing the long-term benefits that, well-meaning providers and development professionals want to provide and give. So you recognized that suitcase medicine wasn't doing it. How did you then evolve into thinking of a sort of a more servant-oriented technical support to the communities you worked with? You've described the wells in rural Uganda, but where did you start to see that you were beginning to have actually a meaningful impact?
Yes, I started in Uganda and then refined my choices of global health groups I was working with, and which approaches I was choosing to follow, and which agendas I was following. So we all have agendas if we're doing work, but are they agendas that are helping local people, or are they agendas that are self-serving, make us feel good? So I became very critical of charity. Although in college, I was this charity, basic community service organizer in a community service dorm. So I very much followed the methodology. Then became very critical of it. Charity's doing things for other people and giving them things. It's not giving them the power to control their own health and in their own healthcare and to do it in their own way. And charity actually disempowers communities. And if communities are empowered, then they have little interest in charity. They have little need for charity, but basically little need for outsider involvement, which really is the goal, to work ourselves out of a job. So I became basically obsessed, with the notion of, boy, what does the evidence show in the literature, and what do I see in my experience working with these groups in terms of how can we empower communities as much as possible? Which approaches are going to help improve health status as best we can, which are going to be sustainable as well. So through these journeys, I went to many areas that are chronically poor, and also did disaster relief a couple times in Haiti, Dominica, and Burma. And there were certain experiences that really stood out for me, and showed me that these approaches can be extremely, extremely helpful. For example, going into a community in El Salvador, where refugees had fled the civil war and came back to their home village. They analyzed their health issues, developed really impressive health programs and human rights programs, including those targeted at HIV and alcoholism. And they really positioned outsiders to be supportive partners very much in the background, which is exactly where we should be. They were the center stage, and they did incredible work. So at residency, I did a global health residency, and we partnered with Lenca indigenous people in the mountains of Honduras. And over a series of trips, I really saw that they did a tremendous job working on all these public health programs in tandem, developing fish farms, developing sustainable agriculture, piping spring water to their villages and houses, building latrines, small microfinance projects to improve gardens and nutrition. Very inspiring. I spent 2 years in rural Puerto Rico providing primary care and partnering with an environmental health initiative, and learned a lot about sort of the dependency relationship in the United States that creates many problems, but there are many inspired people fighting against it and being sustainable in their work. My wife and I also spent 2 years in Botswana and Tanzania, and it was a health system strengthening partnership with the Ministry of Health and others. And we trained local providers to do an even better care doing HIV work, TB, and malnutrition care. And we learned a lot from them in the process. And also we did 3 trips to Sierra Leone, in which we sat down and brainstormed with folks. Look, we're in focus groups, and tell us about your main health issues. What do you want to work on? Water and sanitation was really at the top, and not wanting to repeat previous mistakes. I really sought out the local assets, the people that were movers and shakers and had knowledge and wanted to make improvements in water and sanitation. Turned out there were water and sanitation committees that had died. And the project was really to resuscitate these committees, to do teach-ins, get folks inspired, do community walks, community mapping. And they elected women to lead these committees, and they did tremendous jobs identifying many ways that can improve their water and sanitation. So across this journey, over these many experiences, I wanted to share many, many stories about methods that I've seen work quite well and that the evidence supports as well.
You talk about community leadership and that the support of international partners like yourself is to be in the background. How does that actually work out in practice? Because, we have in our minds this sort of, how shall I call it, Facebook charity where folks, go into communities, have photographs taken of themselves. I'm using that as a sort of a fairly extreme example, but the point is that the donor, the expert coming in from the north is very much center stage. So how do you not even get up on the stage, as it were? Are there examples in the book that you've been able to identify?
It's a great question. Many, many, many examples. And I think it really depends which approach and which agendas we're choosing to follow. So we talked a bit about suitcase medicine, and it's inherently top-down, outsider organized. You're providing free healthcare, apart from the public health system, and commonly causes quite a bit of damage, causes economic harm, in many cases, it's been shown to increase the unemployment rate of local health workers as we come in frequently and create a dependency, and it lowers the self-confidence of the community to take care of themselves. Also, we come in pretty clueless. We're medical tourists. We don't know about the culture and the needs and the language. It's quite easy to cause harm, and quite a bit of that has happened. It's been documented, unfortunately. Now, the second, what I call traditional approach that has been followed for many years, and groups, unfortunately, are commonly still following it, especially clinical groups, is outsider-led health facility building, which again is inherently top-down. It's outsiders saying, "Oh boy, your community needs quite a bit of healthcare, and your health services in the facility are not very impressive. So we're going to build our own. It's going to be better funded, more efficient, have more supplies." And what it tends to do is to pull staff away from the local health facilities and take resources away and take confidence away. So what often happens is the local health facility then becomes crippled and many times closes. And meanwhile, we have to say, well, boy, is the outsider facility going to take care of the job and be sustainable? It's the aim, but in practice, for a wide variety of reasons, it typically closes down. And this is a devastating blow to healthcare. So when we pick these approaches, I think they're inherently not going to have local people in center stage. But of course, if local people decide they want to build a clinic and they lead the whole way and they are there every step of the process, and we're very much in the background, I think it can be helpful. So the other 5 approaches that really I spend the bulk of the book describing methods that have worked and many examples, they inherently place local people in the center, but we have to be cautious and make sure that it actually happens. So number 1 is training health workers. We have massive shortage of health workers around the world. For example, in sub-Saharan Africa, it's over 4 million. Currently, it is projected to increase in 2030 to over 6 million. So how can they have the healthcare that they need without the workers? Further expanding the training of these workers is very, very helpful. And many times clinicians can only go or students for like a 2-week trip, or we can do a good deal of training on 2 weeks, and training new health workers as well. But it needs to be topics selected by local people, and it needs to flow in both directions. Otherwise, it can be a top-down sort of lecturing process that makes people feel less intelligent. Of course, local people are very smart, very experienced, do a good job caring for their folks. In addition to clinical training, another approach is public health training. As we work in these public health areas, whether it be indoor air, water sanitation, etc., we can prevent disease, expand vaccination programs, and so forth. So training public health workers and going over with public health teams and putting, of course, as always, local people in the lead of these teams can be quite helpful. Additionally, strengthening the health system in one or more ways can be tremendously sustainable work that can cut across so many different diseases and so many different demographic groups. Whether that be, doing quality improvement work, making the medicine distribution system more efficient. Of course, the topics need to be selected by Ministry of Health, by the facilities, the local health workers. But again, if we partner in the background and do the uncomfortable job of joining an unfamiliar system that may have many inefficiencies and may be difficult to work with, it's tempting to just create our own, but it's just not as helpful. Additionally, community-based programs in which local people build them, brainstorm, figure out what assets they have, what problems they have, how they want to use their assets to solve their problems, and build it up and take it where they want to go and scale it up. This can be really helpful. And sometimes they would like outsiders to be facilitators of the process if it's not already started. And I really enjoy this work. I did a lot in Sierra Leone and cite a lot of examples of this, but it's ideally done, the facilitation also by local people. And if they identify just a few resources that they lack, and if they say, look, could you help out with these? And we have a supplementary role, it can be quite helpful, or to troubleshoot problems too. Additionally, in the last approach that I read extensively about is professional disaster relief. So not simply waiting for a natural disaster or a war and coming in and seeing as many patients as you can, but following an evidence-based public health approach in which you're really addressing the basic needs that are unmet, whether they be housing, food, security. And folks that love to go abroad and do healthcare, this is a really nice field to get into as long as you're part of a team that's doing bigger public health approaches. And it can be quite helpful to see patients, in these settings, because
Maybe the health facility's been bombed or destroyed by an earthquake, and they may need temporary supplementary care.
This podcast is housed by the Global Listening Project, which is a spin-off of the Vaccine Confidence Project. And it actually speaks directly to what you're talking about, the idea that we have to build preparedness in advance for a range of potential crises in front of us, whether it's pandemics or whether it's disasters, the consequences of wars or civil wars. And so, one of the things that I think is really interesting in this work is sort of moving beyond the authorities at the top of the pyramid, as it were. Because one criticism might be that we're essentially replacing the prejudices and priorities of northern institutions with, political, governmental institutions that might also not be as closely connected to communities as they might be. And so how do you advise going? Do you go to communities to ask how you can help, or how do you put yourself in a place where you can be responsive to requests that they may have for your expertise?
It's a great question. I think it's very important to not go abroad unless there's a genuine invitation to go. And typically, folks are applying to work with pre-existing global health groups to volunteer or to work abroad. And I think it's very important to do the research and look at the agendas of this group and whether they've really rooted them in the agendas of the community, what they want us to partner with, and if these partnerships always have to be locally led. So doing this research before going abroad, I think is critical. Otherwise, you can join what I would call a neo-colonial global health group that is imposing the decisions and values and guesses at what is most needed in these communities. And there's a lot of that going on. And I've ended up being part of multiple groups that do this. And as soon as I see this happening, of course, I try to shift the group in a more productive direction and further empower the communities, give them more of a voice. But if the outsiders are not listening, I leave the group and look for more genuine, sincere partners, because there is so much around the world in terms of, as you mentioned, the importance of this decolonization agenda. There's so much top-down work that is hurting more than helping. I write 2 chapters on social justice because I believe this is the root of public health, and public health is the root of global health. So we need to look at the history of global health to appreciate why empowering local communities is so important. And it's such a radical shift from how global health was first born. So it was rooted essentially in largely European countries, colonizing many, many places, stealing resources, stealing people, leaving these places further impoverished. And then that was essentially where tropical medicine came from. Well, we care about the health of the colonists, so we want to help them deal with these diseases. They were not aiming to improve the health of populations. And this was, followed by many vertical top-down programs that were focused on certain diseases, and they were not rooted in the community voice. They really didn't work. And unfortunately, we see the legacy of this. There's so many top-down programs continuing, and there's so many ways that outsiders are further harming lower-income nations and stunting their health. I review some in the book, like, for example, the illegitimate debts that rich countries are expecting these very poor countries to pay rather than paying for their health needs and addressing the social determinants of health. This is critical. Meanwhile, the IMF and World Bank come in and say, well, we'll give you loans, but you have to further cut your health services. You have to further cut your education services, which is adding fuel to the fire. Meanwhile, rich countries are recruiting the health workers that are desperately needed in resource-limited nations. This brain drain is shameless, and it needs to have a binding treaty to prevent it. At the same time, rich countries, are, and the most wealthy within them and the largest corporations within, especially fossil fuel corporations, are creating climate change. And we're in a world where resource-limited countries are facing the worst effects from this. And meanwhile, our rich nations are not providing climate reparations that they can adapt to these horrors.
programs that try to reverse this artificial dependency on rich countries are really brilliant, like the technology transfer hubs that are going abroad and helping folks to manufacture their own medicines and their own vaccines. This is so important. After all, look what happened with the pandemic. You mentioned emergencies in global health. The COVID pandemic, rich countries hoarded the vaccines. And even today, if you look at the numbers, sub-Saharan Africa, many countries are only something like 20% vaccinated. And this is a legacy of this, institutionalization of selfishness, basically. And so we need to reform global health on so many levels, including these macro levels, like the World Trade Organization, has dramatically worsened this situation by negotiating the TRIPS agreement. And there's supposed to be, so it protects intellectual property rights, including vaccine patents. And you have this life-saving COVID vaccine, well, multiple ones circulating, and resource-limited nations do not get it. There is a waiver that is supposed to apply to pandemics, but it took nearly 2 years for this waiver to be implemented. And of course, the pandemic at that point, it wasn't really needed. Meanwhile, these are 2 years that all these nations could be making their own vaccines. They were, pushing the WTO. Please let us do this. We want to prevent all these unnecessary deaths. There's so many ways, including a pandemic treaty, that we could prevent problems like this. It needs to be binding. It needs to allow the distribution of vaccines based on the number of people in need, not based on how rich a nation is. WHO needs to be dramatically funded. There's so many levels in global health we can do less harm, and we should.
Which sort of gets us on to one of the other big questions I had reading the book. And you approach public health, you approach the provision of clinical services actually in a very political way, actually. The interventions that you see communities asking for are essentially the basic tools of democratization, education, local health workers there to provide primary or universal health coverage. And, you've also taken a very strong interest in the One Health agenda, which of course connects the dots between the way we treat our environment, the way we interact with animals, and of course, and then the way that that we ourselves get put in positions of exposure to new infectious disease threats. And I wonder, we'll come on to the advice you're giving to young folks wanting to pursue careers in global health. But I wonder, given these structural obstacles, do you really think we can make a difference as workers in global health?
It's a great question. I really like the term that the late Paul Farmer used, the structural violence, and it is the very structure of society, and especially our economic system, that I think is creating so much of the ill health around the world. And actually, there's tremendous evidence to support that claim. So is this political work? Yes, all public health work is political. It's a dirty term, but it's deciding society's priorities. Do we care about preventing disease? Do we care about housing? Do we care about education? Do we care about expanding healthcare? I hope folks are answering yes, and they're saying, look, we need to become advocates. And I've been talking about macro level issues. I know you often do on your show, but I don't think folks have to get involved in that level if they're not comfortable. Simply going over and being a good partner, and facilitating local people to lead the way and saying, look, I want to support you. I want to learn what's going on. About your community health problems, and I'm sure you've thought about solutions, and maybe you already have programs designed at them. Would you want us to partner, and could we assist you in some small way? Coming in with this humble kind of evidence-based approach, I think, although it may seem quite small, compared with the daunting challenges in global health, but if every global health organization was taking this approach
would have so many ripple effects, and it could really help to shift, the empowerment status where we saw some of the nations have so much more control over their health and healthcare, and rich nations have so much less, which is a very good thing.
As you look back on your career, how have things changed? Less say from a structural level, but from the kind of health challenges that you were being asked to help communities respond to or prepare against. For example, did you see the HIV epidemic transform your clinical work and your public health work? Or were there other challenges like vaccinations of young kids? What was the feel of the sort of the journey that you had over your career? Have had over your career, because your career is by no means over. I apologize for that.
Thank you. Yes, it's true. HIV has had a big effect. That initial trip to Uganda, in that area of the country at the time, they were estimating 30% HIV prevalence rate, which is very much why they asked us to do education and to train folks to be educators. And then we ended up, hiring local groups to do more testing and counseling. And so it very much informed the work that we did. And as I was, in medical school, and of course I went into family medicine, but I became an HIV specialist and a tropical medicine specialist. After being abroad on many, many trips and seeing the great need for that not only HIV care, but, this partnership of mutual support, and can I help troubleshoot and answer questions and connect you with resources that can help with this important work that you're doing. So we've seen some dramatic improvements, of course, in the scale up of HIV care, but there are so many challenges yet to emerge, and even we see, you're talking about global health trends, with the COVID pandemic, of course, so much attention shifted from HIV care programs and TB care programs and these malaria initiatives that were finding much success, and vaccination programs that had tremendous rates, finally in many lower income nations. And then COVID enters and, of course, distracts attention, importantly. And, we're really seeing a crisis now of dropping vaccination rates and increasing cases of TB and more drug resistance. So there are so many challenges, and these larger global level trends, shape really every type of global health program under it.
You've mentioned Uganda a few times, and I guess I have to ask you this. Uganda, of course, has been much in the news in the last few months over the passing of a new piece of legislation that further persecutes the LGBT plus communities. And I wonder what your thoughts are about it, and how your methodology of support to communities themselves, how that then fits into this. Where I'm going with this is there a tension between what communities say they want versus the sort of rights-based approach that public health has started to embrace over the last few years? I mean, is there a tension there, or is it actually totally manufactured?
I haven't studied details on this legislation, but I've read about the basics, and it sounds very, very troubling. And this puts outsiders in a dilemma, because we want to advocate for systems and laws and policies that are open to the LGBTQ plus community receiving excellent healthcare as they deserve. But if we're working in communities where the majority of folks are supporting this legislation, it is quite difficult to know when to speak up. It's very important for us to be honest and share what we believe, but these are not our societies to determine what their governments are going to do and what laws they're going to pass. This is the job of the people. There's so much social injustice out there, and outsiders could come in and start movements and revolutions and say, look, you need to make your country go in this direction, and this would, although it may improve certain aspects of human rights and public health, such as this example,
it would be a neo-colonial relationship. Again, us coming in and telling folks what to do. So I think modeling, just work and just behavior and just policy, can be a very important message, and seeing opportunities to share these messages and hopefully get folks thinking about how they could be more open and do a better job helping their own people.
And of course, in the case of Uganda, there have been reports that, in fact, it was the US far-right religious groups that helped craft and help pilot this legislation through. It's not something new. It's been, unfortunately, something that's been building up for a good few years. So yeah, I think you're absolutely right, and it's again speaks to us as servant leaders rather than, and I pick this word deliberately, rather than crusaders. So you put together the book. You worked with Hesperian to publish it. Why Hesperian? What's the collaboration been like for you with Hesperian?
Yeah, so I've read a number of Hesperian books, and I've used them where there is no doctor helping health workers learn. I find these very, very helpful books to pass on to health workers abroad and to assist with their training. So Hesperian's a very inspiring publisher that basically, publishes these manuals and books in medical empowerment. Obviously, I'm a big fan of medical empowerment, and I thought this would be the perfect place to house the book. So I was, very excited when they expressed interest in publishing it. So they're really doing incredible work, trying to get these books translated in so many languages to empower health workers to do a better job with care, even folks in the middle of nowhere, where they have a real shortage. It's not like you have to give up on healthcare. There's a lot of very important lessons. They use illustrations and very basic language folks can understand. And additionally, they're supporting the people's health movement. They have health wiki and apps. There's so many levels that Hesperian can encourage, the sort of grassroots agendas I've been talking about.
Yeah, it's funny, isn't it? I mean, there they are, established in the 1970s. The written word and the written graphic and comic, if you like, is what they're rooted in. And it's fascinating to see them now looking at digital video and app-based approaches to their services. I mean, I've got to say, I found the publications over the years, particularly in relation to HIV, hugely helpful to people like myself who perhaps can't review and stay on top of the published peer-reviewed medical literature. So they've been really helpful aid memoirs. And I guess, Kirk, that gets us really to the future and what happens from here. I loved that you were really bringing the richness of your expertise to help inform and encourage people thinking about careers in global health. What would be your message to them around what they should do and where they sort of, let's say, leave their white coats in their laboratories?
Oh, sure. Well, I would really encourage folks to not be overwhelmed by the many global health challenges, to focus on, if you have that inspiration and interest, please stick with it. We really need your help in global health, especially if you're going to be, a humble partner in the background and have local communities lead. But I would encourage folks to spend a good deal of time studying and preparing before they get involved in this work. I think studying the history of colonization and globalization is very important. Studying public health extensively in the whole field of global health. And I think, having as much experience as they can have in resource-limited nations, whether it be a study abroad program, an internship, extended living in these communities, learning about the language, learning the culture. And I would say, very importantly, developing equitable friendships. And, once folks are, have a large group of friends in resource-limited nations and say, oh boy, I really respect these people. These folks are very smart. They're very capable. They're doing great work. When you're in that position, that I think you're ready to be an equitable partner and to start getting involved in global health work. So many folks, I mentioned that charity mindset, that they see the images on TV and that, oh my gosh, they're these starving people
without healthcare, anything that we do, anything that we bring over to them, we got to donate things, we got to give them free care. All these things will be very helpful, and it's an intuitive leap, but unfortunately, the evidence shows it just is not there. So when you're sort of primed to have this background and to really treat folks as being very capable, and you as being supplementary, and maybe you won't even be asked to come, or maybe you get there and they say, "Look, we're doing great. We'll teach you some things, but we don't actually need your help." The afterword of the book involves Robin Young and Jessica Everett from Child Family Health International answering that question. And with the expression, don't just stand there, do something. They flip it on its head and say, don't just do something, stand there. And that is their advice for students of global health. Don't just jump in there and be inspired by the challenges and just do as much as you can. Be deliberate, learn as much as you can, do a lot of observation, and slowly get yourself more involved in the capacity that you're being a helpful partner.
Kirk, this has been a really fascinating and challenging conversation. And I mean, here we are, a podcast, an audio video podcast, but a podcast nonetheless. And so words matter. And I sense that you and I are sort of struggling with capturing the right words and the right phrases and the right descriptions of what it is that needs to happen going forward. On one hand, people might say, why are two white men having a conversation about global health priorities? What do we know? But I guess the point is that's precisely right. What do we know? And it's a question of providing our tools when invited to communities to help them utilize them as best they can.
I think that's really well put, Ben, and making sure that our largest lessons are coming from the communities themselves abroad. As I would say, definitely my enduring lessons came from them, and that's exactly where they should be coming from.
The other part of it, which we referred to or alluded to, but the learnings are actually two-way. And I've been really fascinated over the course of the pandemic to see how First Nation communities in Canada, Native American communities in the United States, and particularly the Cherokee and Navajo nations, have actually provided, I think, really incredible insights in how to address and rebuild trust in medical services, the role of young people as educators of elders, and the utilization of established values and rituals and belief systems to help reinforce innovative approaches to providing healthcare that are bottom up rather than top down. And I really think your book helps really reinforce that.
Well, I appreciate you saying that, and I do agree. I think Westerners can learn so much from Indigenous communities, and there's such a history of sustainable living, living with the environment, considering the environment part of health as it is, and not something separate, and being very grassroots and seeking consensus, and not looking to who's powerful. Well, this is our leader. Our leader determines our policy, whether it's going to help people or not. So there's so many lessons for global health that I feel Indigenous communities can provide for us.
Well, Kirk, thank you so much. You really are a shot in the arm. Thank you so much for a really invigorating conversation. Your book, Doing Global Health, by Kirk Scirto, available through Hesperian on website, and you can Google it and find it very easily. Thank you so much for being on the show today.
Thank you so much, Ben.
Well, that's it for this episode. Thanks to Kirk Scirto, and don't forget to check out his book, Doing Global Health Work. It's available on Hesperian's website and at all good bookstores. Thanks also to Vanessa Tran from Hesperian for perseverance in helping us schedule the recording of this episode. As always, thanks to our director and producer, Erica Spera from Newsdoc Media, and a particular shout out to our production assistant, Waisha Raphael, who researched today's episode. A Shot in the Arm podcast is a project of the Global Listening Project and a member of the Health Podcast Network. You can find us on all your favorite podcast platforms and on our YouTube channel. And if you haven't already, please do subscribe for prompt access to new episodes from this and our sister podcast, The Global Health Diplomats. And finally, have a great week and a safe week, everybody.